Okay. Yeah, good morning and welcome to today's clinical meeting. And we have got 5 presentations today. So we'll start off with medicine one, Dr. Vagishvar presenting on to do or not to do.
Good morning to all. Today I am going to present to do or not to do. This is a 73-year-old female from Nellore came with a complaint of nausea and vomiting for 4 months, abdominal pain for 4 months, and unquantifiable weight loss for 4 months. And instead of presenting illness, she presented with a vomiting 2 to 3 times per day, 5 to 10 minutes after eating food, which was non-bilious, not bloodstream, contained food particles. And she had a history of 3 episodes of coffee-colored vomitus, and there is a history of abdominal pain, more in epigastric region, worsened after eating food. There is no radiation of pain. There is a decreased food intake, history of decreased food intake with weight loss. No history of melena, no history of fever, cough with hemoptysis. She is a known diabetic and hypertensive for past 20 years on medications, and she is a known recently diagnosed hypothyroid on thyroxine 50 microgram once daily. She is a postmenopausal lady for 20 years. On examination, general examination vitals are stable. General examination findings showed a pallor, and the system examination showed abdomen some diffuse tenderness, no organomegaly, no free fluid, and CNS examination showed bilateral absent ankle jerk. This is a summary of case. A 73-year-old female with diabetic and hypertensive with abdomen pain and chronic abdomen pain and vomiting for 4 months with 3 episodes of hematemesis and weight loss with pallor and diffuse abdominal tenderness on examination. Differentials. Differentials considered was a gastric or upper GI malignancy, peptic ulcer disease, chronic mesenteric ischemia, vascular causes like diaphragm lesion or cave, or gastric varices secondary to underlying portal hypertension. And in investigations, hemoglobin was 10.4, total counts are 11,800. Electrolytes and urea creatinine and LFT are within normal range. Calcium phosphate was 8.87 and phosphate was 3. TSH was 0.157 and A-time cortisol was 36 and HbA1c was 6.3. Iron TA-base was low with normal vitamin B12 and folic acid. She had one episode of hematemesis involved with a drop in hemoglobin from 10.4 to 8.3. So we had done a gastroscopy which showed a multiple esophageal and a gastric ulcer, the forest 2C and 3 classification. And biopsy taken from a esophageal ulcer showed moderate chronic gastritis with mild activity, and from a gastric ulcer showed moderate chronic gastritis with moderate activity and ulceration and surface candidias. Done a PET CT abdomen to rule out a malignancy. It showed thickening of lower end of esophagus and cardia, fundus, and the proximal body of stomach with the diffuse atherosclerotic changes with the thrombus extending from an abdominal aorta, causing a complete thrombosis of celiac trunk and thrombosis of splenic artery. And the final diagnosis we have done was esophageal ulcer and first 2C and 3 gastric ulcer, probably secondary to ischemia. And there is an extensive atheromatous thrombosis involving a multiple large vessels, abdominal aorta, celiac trunk thrombosis, and splenic artery thrombosis. This is abdominal aorta and celiac trunk branches. Abdominal aorta usually supplies a bowel by celiac trunk superior and inferior mesenteric arteries, and celiac trunk has branches of left gastric and splenic artery, and also common hepatic artery divided into gastroduodenal and proper hepatic artery. Thrombosis of celiac trunk caused the left gastric artery blockage and lead to ischemic ulcers. This is a study related to mesenteric artery disease in elderly. This is a cardiovascular health study in USA. It's an observational cohort study done in a patient aged more than 65 years. Visceral duplex scan was used to look for a mesenteric artery stenosis. In that, 97 participants, 1,500 was screened, in which 97 have mesenteric artery stenosis, in which 83% have isolated celiac artery stenosis, and 7 persons have a combined celiac and SMA stenosis, and 5 have isolated SMA stenosis. SMA and celiac artery stenosis demonstrated independent associated with the annualized weight loss. Just few words about celiac artery thrombosis. The risk factors of celiac artery thrombosis are old age, hypertension, diabetes, dyslipidemia, and smoking. And the most common cause will be generalized atherosclerosis, vasculitis, malignancy, and hypercoagulable states. Management of celiac artery thrombosis is mainly a treatment of underlying cause and treatment of specific lesion by endovascular thrombolysis and stenting, and thrombectomy and vascular bypass. We have to assess a viability and resect an infarcted bowel in acute intestinal ischemia, and we have to start a antiplatelet and anticoagulation therapy. For our case, after 4 days of admission, she developed a sudden onset breathing difficulty and tachycardia, and ECG showed a dynamic XT depression in infralateral lead, and there is a serial elevation of TROP-T and CKMB, and diagnosed as an NSTEMI, and echo also showed global hypokinesia with LV systolic and diastolic dysfunction with reduced ejection fraction. So we have abdominal aorta and celiac artery thrombosis with NSTEMI requiring dual antiplatelet and therapeutic anticoagulation. On the other side, she have a multiple esophageal and gastric ulcers with ongoing hematemesis. Now what to do? They have get an expert opinion from a cardiology. They advised endovascular stenting with the thrombolysis for reperfusion of celiac artery, but it was withheld due to the recent hematemesis and multiple ulcers. We need a clinical judgment, and we have to outweigh the benefits and risk to decide which therapy is suitable for a patient. This is a study related to ischemic gastropathy treated with celiac artery revascularization. It is a case study. It showed a 73-year-old diabetes and hypertensive with upper GI bleed. An abdominal angiography showed a celiac and SMA stenosis. So they developed a ischemic gastropathy, the anterior gastric ulcer, and they managed with the endovascular stenting and revascularization followed by anticoagulation. This is another study related to GI bleeding and anticoagulant or antiplatelet drugs. This is a systemic study. There is no specific guideline for when to start an anticoagulant in a GI bleed or any major bleeding events in a patient. This study compiled all the more articles and showed immediate risk to a patient from hemorrhage may outweigh the risk of thrombosis. So we have to wait to start an anticoagulant or antiplatelet therapy. In major bleeding events, always requires interruption and neutralization of both anticoagulant and antiplatelet therapies. Neither anticoagulant nor antiplatelet agent should be reintroduced until strict control of hemorrhage has been achieved for at least 24 hours. the main, this is an Hippocratic oath of first do no harm. If any intervention which causes more harm to the patient than benefit, then we have to withhold the treatment. In this, our patient, we have managed a conservative line of management with least therapeutic intervention, and discussed with the family about a treatment option as well as benefit and risk involved. Due to multiple GI ulcers, recent hematemesis, and significant drop in HB, aspirin and therapeutic anticoagulants are not given initially. She was started initially on clopidogrel and statins. And we observed a patient for 1 week. There is no further episodes of hematemesis and GI bleed. So started on therapeutic anticoagulation after 1 week, followed by low dose warfarin. And she was well and discharged to follow up with the cardiology after 1 month for a definitive management. This is probably she may not develop to infarction due to the collateral arterial interstitial circulation. Usually mesenteric arterial circulation is characterized by numerous collateral pathway which protect the bowel from potential ischemia or infection in a situation where arterial supply is compromised. This diagram shows SMA and celiac artery. There is anastomosis by a pancreatoduodenal arcade, and SMA and IMA by arch of Riolan, and SMA and IMA another by a marginal artery. The learning point in this case will be any elderly patient presenting with chronic abdomen pain, vomiting, and hematemesis consider a diagnosis of mesenteric ischemia, and importance of clinical judgment in weighing the benefit and risk and opting the treatment tailored to each individual patient strategy. In a practice, physician is faced with a unique therapeutic situation. The physician has to examine all factors together to come to a prudent clinical judgment. When a risk of harm is greater than a benefit of treatment, the physician has to take a wise course of withholding treatment. Such a decision is not a passive decision, it is an active one. Taking the patient through a life-threatening illness with the supportive treatment is an art. This case demonstrates that therapeutic minimalization based on clinical judgment can be a successful management. Thank you.
Thank you, Vagishvar. We open the topic for discussion. And any questions from the audience?
So this case actually highlights how to handle a complex situation. Many situations in clinical medicine are highly individual. Now, when you think of a bowel ischemia, it's a life-threatening situation. A person has a bowel infarction, the only treatment is surgical resection. This patient actually had a complete iliac artery thrombosis, but had not gone into a bowel infarction. But this patient was also bleeding. And the question was how to balance the risk and the benefit. She was actively having hematemesis. Hemoglobin was dropping. So obviously the wise course is to withhold antiplatelets and anticoagulation. But you always run the risk that the mesenteric ischemia will likely worsen and you'll go into a bowel infarction and you'll have certain death. So in this situation, you have to use some wisdom and to choose the correct course of action where the patient will have no harm and a possible likely benefit. This patient came out and we were not sure how this patient will go. But in this situation, if you're choosing no intervention, you need very good quality clinical care to support this patient. So the point that I want to add to the presentation was how that happened. So this patient actually, we were managing conservatively. She's continuing to have abdominal pain, okay, and abdomen was actually tender. So in one round, the family was there, patient was there, very tense. And the only thing that I did that time was to talk to the patient. And I held her hand. I spent a little time, but the next morning, actually the abdomen calmed down. She settled down completely and she went home within a week. Now you'd ask, what is that? What is holding her hand? And what does that have to do to recovery of collateral circulation? We don't actually know the answer to this. What we do know is that we actually did not do anything for this patient. But she came out from a potentially life-threatening situation. That is an art. Okay. So doing nothing is also an art. Sometimes the patient can come out of a catastrophic event.
Any other questions? We'll move on to the second presentation by Medicine 2, Dr. Pranuth Livingston on 2 by